If you are overweight, obese, pre-diabetic, or have type 2 diabetes, this protocol is for you. Only 12.2% of American adults are now metabolically healthy. 86 million adults in the US have pre-diabetes, and 70% of these individuals will eventually develop diabetes. Being overweight or obese is the main factor for progression to diabetes. The best way to reverse diabetes is to not get diabetes in the first place, because your chances of heart disease, cancer, and death are increased even as a pre-diabetic. Our protocol offers real hope and transformational change to patients who would otherwise be consigned to a lifetime of medications, doctor's visits, and suffering. Welcome to ReverseDiabetes.md.
Hi, I'm Dr. Gurpreet Pata. I'm a board-certified anesthesiologist, interventional pain physician, and addiction specialist. Today I'll be talking a little bit about one of our protocols that we utilize to help patients with obesity, prediabetes, and diabetes type 2. I get asked a ton of questions about why we get sick. Right now, 87.8% of the US population is unhealthy. They have chronic disease. That leaves only 12.2% of the American adults being metabolically healthy. 86 million adults in the US have prediabetes. Hemoglobin A1C is at 5.7 to 6.4. And 70% of these individuals eventually will develop diabetes. And that rate actually may be higher. It may be actually 80 to 90%. Obesity is the main factor for progression of prediabetes to diabetes. Obesity is the main factor of progression from obesity to prediabetes. So there's only about 20% of patients that get prediabetes that are not obese. We consider it adamant to treat this population because what we deal with on a nearly daily basis is severe metabolic inflammation. And that metabolic inflammation is reflected in the overall metabolic status of the patient. And that's a combination of insulin levels, which are hyperinflammatory, and GGT, which is a marker of poor health and insulin resistance in the liver. In our clinic, almost all of the patients that present to our clinic have significant issues associated with pain, which is a hallmark of metabolic inflammation or meta-inflammation. The majority of patients that present to our clinic are overweight. I would tell you probably 85-90%. And when we look at their biochemical markers, they're pre-diabetic, have metabolic inflammation, and are already on their way to diabetes. About 40 to 50% of our patients that we see are unrecognized classic type 2 diabetics. When you have a pre-diabetes picture or you have a metabolic inflammation picture, which is pain plus obesity, you get changes in your immune cell concentrations, you get changes in your immune cell function, you get increased migration of inflammatory cells, you get upregulation of cytokines, and these inflammatory cells go to areas that are already inflamed, areas that are already painful. So our clinic may be a little bit unique because what we see is systemic metabolic inflammation already. I don't think it's that unique because I think that a lot of primary cares and a lot of general practitioners and even orthopedic spine surgeons, they also see metabolic inflammation as a key element. And remember, only 12.2% of the population is healthy. So no matter which way you slice it, the vast majority of patients are going to have significant metabolic dysfunction. If you rely on hemoglobin A1C alone, you underdiagnose 73% of adults. Underdiagnose 73%. Not over, underdiagnose. If you look at the 2019 American Diabetes Association Standards of Care, they recommend treating patients with hemoglobin A1Cs between 5.7 to 6.4. They're the ideal candidate for diabetes prevention efforts. That's the critical and key element. That's where you can institute lifestyle and behavioral changes that make a huge difference. You can use weight loss, dietary changes, self-efficacy changes, you can get about a 7 to 10% weight loss, and you can reverse their disease right there and then. American Diabetes Association recommends in patients that are increased risk to use metformin, even in those low-level hemoglobin A1Cs, as long as the patient's less than 60 and they have other markers of metabolic inflammation. Prediabetes is associated with increased cardiovascular risk. Your cardiovascular risk starts in that pre-diabetic stage. The macrovascular damage, the big vessels, the atherosclerosis, the foam cells that macrophages turn into, start in the pre-diabetes range. The microvascular risk, the glycation effects, are later. And they're usually after the hemoglobin A1C hits over 6.5. But by then, you've already established a base of severe atherosclerotic disease that can increase your morbidity and mortality by 200 to 400%. So if you look at what happens early on when you have normal glucoses, you get normal insulin resistance and normal insulin production. But as your glucose rises, your hemoglobin A1C does not necessarily rise. What's happening is that you start to increase your insulin production. And only when you can no longer continue to increase your insulin production and you're in full-fledged insulin resistance and you start to get beta cell depletion, does your hemoglobin A1C suddenly rise. So there's a lot of times that I find patients with near normal hemoglobin A1Cs. Hemoglobin A1Cs of 5.4, 5.5, 5.3 even. But their insulin levels are high. And their fasting insulin glucose tolerances are abnormal. Their GGTs are starting to go up. And these patients are pre-diabetic even though their hemoglobin A1C is in the normal range. You're already sustaining significant macrovascular damage at those lower levels of prediabetes. The microvascular damage comes later. Insulin is the disease. Insulin is the problem. Measuring the glucose and assuming that the glucose is the problem when it's just a symptom doesn't let you treat the patient adequately. The issue is the hyperinsulinemia and the insulin resistance. The glucose is the end result of all of this, and it's just the symptom of a dysfunctional insulin system. For type 2 diabetes to occur, you have to have both insulin resistance and eventually inadequate insulin secretion. But prediabetes is insulin resistance with adequate insulin secretion and perhaps even a normal glucose. But that's where the cellular damage is occurring. The cardiovascular risks are from the macrovascular damage. It's from the insulin resistance, even before the glucose level is chronically elevated. That macrovascular risk is very, very significant, and that's what we're trying to eliminate. That's what we're trying to reduce when we treat patients early. The increased risk of adverse cardiovascular outcome is associated with type 2 diabetes does not begin at the diagnostic cutoff of hemoglobin A1C 6.5, 6.6, whatever you wish to choose. It actually starts in the pre-diabetic dysglycemia. It starts with the increasing insulin and the increasing insulin resistance. The glucose is the symptom that things have gone terribly wrong. But what started going wrong already happened with the insulin. The GGT will reflect that. In the ACCORD trial, if you could keep hemoglobin A1C reduced, that 1% reduction in hemoglobin A1C reduced mortality by nearly 66%, and that was using the Metformin monotherapy treatment. So our goal is early intervention. We want to prevent atherogenic prediabetes, and we want to maintain hemoglobin A1Cs below the pre-diabetic range. We want to do everything we can to improve the patient outcome. We don't want the patient to go on to plaque formation. We don't want them to have progression of metabolic inflammation. And we believe that this is a very cost-effective way to treat this patient. We believe that this is disease modification at root cause rather than symptom treatment later. If you delay treatment to later with hemoglobin A1C greater than 6.5, you already have destroyed the glycocalyx, and you've already sustained endothelial damage, and you probably already have irreversible diabetes-specific microvascular complications and macrovascular complications. Now, we acknowledge that if you are overly rigorous with blood glucose control, especially if you add other hypoglycemic agents to metformin, you can have a very significant issue of hypoglycemia. You can have a very significant untoward outcome. But if you stick to metformin monotherapy with lifestyle change, you don't get any of that. Metformin is an extraordinarily safe, inexpensive drug that produces tremendous long-term benefit. Our early intervention is geared toward lifestyle modification first and metformin monotherapy second. What we want to do is we want to decrease gastrointestinal permeability. We want to get rid of things like glutens and gliadins. We want to reduce the inflammatory load to the liver. We want to reduce carbohydrates, specifically fructose. We want to reduce fat deposition in the liver. We want to restore an omega-6 to 3 ratio that's appropriate. The standard American diet is typically between 20 to 30 to 1 ratio. We want to get this down to 4 to 1, 5 to 1. We typically will recommend 4 to 6 grams of omega-3 fish oil a day to restore the ratio, and then eliminating all of the vegetable oil. We want to improve insulin sensitivity by reducing insulin release, and sometimes we'll use time-restricted feeding to get that. We want to reduce the overall glycemic load that the patient is experiencing. When we do monotherapy with metformin, we typically use that as our first-line drug. We do this because it has a very low side effect profile, except for the individuals that already have some pre-existing renal dysfunction. Certainly that's something that we're very, very sensitive to and want to make sure that that's not an issue. Nobody really knows how metformin works. It could affect the mTOR pathway. It could be an anti-inflammatory. It could really change the gut microbiome. It may affect sympathetic tone. It may do that through the gut microbiome. It may directly affect insulin receptor sensitivity. It may affect the formation of advanced glycation end products, indirectly or directly. There may be some effect on the liver as in terms of releasing glucose into the bloodstream. Nobody really knows. It has a lot of different functions. It may even affect fructose 1,6 biphosphatase and affect the fructose consumption of the liver. Metformin is a drug that has a whole variety of different pathways. It's akin to berberine. We don't really know exactly by what mechanism it's working. We do know it is working, we just don't know the exact mechanism. The longer we delay progression, the more cost-effective it becomes. Metformin costs about 5, maybe 10 cents a tablet. It typically is 5 cents a tablet. And a 30-day supply is about $6 a month. If we treat the patient early and get their disease reversed before they get to hemoglobin of 6.5, 6.7, 6.9, 7.0, we can avoid insulin. Insulin costs is at about $900 a month, and there's some statistics that show that the average is probably $1,200 a month, excluding the injection supplies. So per month of insulin therapy, you could pay for about 160 months of metformin therapy. And if you can avoid getting the patient to insulin, you've saved that patient's life. You've changed the metabolic inflammation, and you've changed the healthcare system. We have over 7,000 patients in our clinic over the last 18 years that we've done this for. I can tell you that it makes a massive difference in their lives because we're able to de-prescribe medications that they used to have. If they no longer have hyperinsulinemia, their blood pressure goes back to normal because their vessel wall rigidity decreases, their vessel wall thickness reduces, their metabolic inflammation loads decrease, their pain load decreases. And so that's our main goal. We look at metformin as an important, necessary item after lifestyle change. Preventing or delaying the formation of diabetes is in itself important. Metformin works even 15 years out. There's some studies that show that even 15 years after metformin monotherapy, patients are still non-diabetic, that we would have expected by hazard ratio to have become diabetic. Metformin is extremely cheap compared to some of the other expensive drugs. And certainly catching a patient before they become diabetic and requiring insulin and other drug therapy is the ideal situation. If we can avoid the issue, if we can treat the root cause, which is hyperinsulinemia, then we don't have to treat the symptom of glucose. Our goal is to reduce metabolic inflammation and avoid those preventable complications, those known preventable complications of insulin resistance. We want to revert the patient to normal glucose regulation and reverse their insulin resistance early.
This has been Dr. Pata with ReverseDiabetes.md. Remember, the information discussed should not be considered specific medical advice and does not constitute a physician-patient relationship. This field is extremely complex and requires a direct physician and patient interaction. Each patient is medically unique and the exact protocol will need to be tailored. If you need further assistance, call our office at 314-481-5000 or send us an email to info@reversediabetes.md.